So these are fully disposable, single patient use bronchoscopes. Okay, they'll be stored in the OR for now. The physicians know to grab the scope, grab the monitor, and come to you. Okay, this is the monitor itself with a charging pack. It does have an IV bracket, so it'll just be on an IV pole. So this is the only thing that would come to the bedside. Okay, the scopes themselves, they do come in 3 sizes. You guys have only purchased the largest one. Okay, there is a quick sizing guide I'll go over also. This is the way that the scope would look in the packaging. Okay, they're sterile in the packet. They're latex free. They do have a 3-year shelf life. Okay, on the back there is an expiration date. Most facilities chart a serial number or some kind of identifier when they do the procedures. You want to chart the lot number. Okay, that's going to be your best identifier for the piece of equipment. When you look at the package itself, it's going to be color coded. There are 2 other sizes that they may order for the OR. We're not sure yet, but just know that they're all going to be color coded. Okay, the orange one is the largest one. It's a therapeutic size scope. It'll fit down a 7 ET tube or greater. Okay, just know that if you're bronching a patient with a 7.0 and you're on the vent, you're compromising your flow around the tube, which means your pips are going to go off, your patient's going to desap faster. Typically, most people turn their patients to 100% to do any bronch procedure anyway, but just be aware, okay? On the package itself, you're going to see 2 sets of numbers, okay? The first set of numbers is the outer diameter of the scope. That's going to be really important for your trachs, okay? Your trachs on the flange will have the inner diameter, the ID. That actually includes your inner cannula on some of your trachs. If at any point they try to put the scope through and have any resistance, you probably want to take out that inner cannula to do your procedure. Okay, you probably won't be able to ventilate, but if they're plugged and obstructed anyway, you're not really ventilating anyway, right? So make sure that first set of numbers is smaller or the same size as that guy, the inner diameter. The second set of numbers is actually the working channel. These scopes have suction and a working channel. So if they actually want to do a biopsy or put a cytology brush through, they can use those tools down the scopes, okay? Really at the bedside, you're not going to be doing that. They're going to be going to the bronch lab for anything like that. But know that there is that capability for it, okay? There is a hook on the package, so you can hook it to the IV pole. We recommend you just open a flap on the top so that you can put the scope in and out as you need to. When you take it out of the package, you're going to notice that I've got a sheath covering my scope. Leave that on until the physician is ready to use. It's going to keep your tip clean, okay? The other one you've got is another protector over your suction port. This is just for transport so it doesn't break. Make sure you pull that guy straight off. If you go down at an angle, you have a higher incidence of breaking that piece off, okay? All of these are going to come with a little packet. My packet broke off. But in that packet, you're going to notice this little tool, okay? This is going to be your slip tip adapter. So you actually need slip tip syringes to go to your working channel. If you don't have them, this is your adapter for your lower lock syringes, okay? You want to make sure that that slip tip is seated all the way in. If not, they're going to have overflow or splashback. There's a plastic valve here. Now those endoscopy tools I just talked about, this becomes your biopsy port, okay? So we need to open that valve to put the tools through and then to be able to get the sample back out. If not, it'll squeegee it off. Okay. If you're not using it or if you're using it, just always keep it on a syringe so it doesn't get lost in the bed. We are working on packaging 3 per scope. Right now we only have 1 per scope. Okay. If you don't use these little packets, take them off and save them because you know at some point you're going to use it and it's going to get lost in the bed. Then you'll have some backups. Okay. The scope itself is a hollow tube. There is no fiber optic in here. Okay. It's 2 LED lights and a CMOS camera like your cell phone. Okay, so if your patient accidentally bites it, it gets tapped, it's still going to function. Okay, the length itself is the same length as a reusable scope. Okay, it's 60 centimeters. The only difference is you don't have that big fiber optic handle at the top. Okay, for your suction, your connection is on the side. You want to make sure that you put that suction all the way through as tightly as possible. It'll give you a better seal. Now, most likely what you're going to be doing is putting your specimen cup directly through. Push that guy all the way over. Adding your suction, and then what some facilities actually do is they'll tape it to the handle so it's not flopping around on them. Okay, so they'll tape it to the handle. The physician will move the toggle with their thumb and actuate the suction with their pointer finger. Okay, if they complain of loss of suction, start with this connection and then work your way back to your canister and then your wall manometer. Okay, most likely it's this seal around. If they are doing a difficult airway insertion, which means that they've got some bad angioedema or they need to do a nasal intubation, you can actually preload the ET tube onto the scope. This is a 7.0, so it's a little resistance. I needed to lubricate it. But the grips at the top will hold the tube in place. So you don't have to tape it or take the connectors off, okay? So you can do their nasal intubation from there and move on, okay? Sometimes you will have to use an oral airway, okay? If you're not using do you use bite blocks on all your intubated patients? No, okay. I would definitely either put a bite block on or do an oral airway. That'll make it more smoother passing through the ET tube, because sometimes you will have some resistance from the tongue and the way to the mouth. Okay, so any oral airway will help. The other piece of equipment you're probably going to need is a bronchodapter. Okay, most of the time your endoscopy labs will have these, but we'll have to figure out where you guys are going to stock them. You are going to notice that when they're inserting the scope through, if they hold too far up, it's just going to bend at that turning angle. They have to hold a little bit further down to get it through. Okay, lubrication, whatever you have available is appropriate. Whether you have KY or Surgilube, there is a silicone spray that they'll sometimes use in the endo labs. Whatever you have is available. There's a green line on the scope. You want to make sure you lubricate from the green line up, never on the tip of the camera. I would have some gauze available as well. Sometimes they'll get secretions on the tip of the lens, and they'll either want to pull out and dab on some gauze. The other thing you might see the physician do is actually tap it on tissue inside the patient to try and get it to remove. Okay? There is no anti-fog on the lens. What we do recommend is you actually turn on your monitor and plug in your scope and then let that light warm up a little bit, okay? So from here you're gonna see it takes 45 seconds for my camera feature to load. If this is an emergency, I don't have to wait for it, okay? There's a blue connector on my monitor, on my scope, and there's a blue arrow on here. You're only gonna be connecting to the blue arrow, not to the green one at the top. You wanna make sure you line up those arrows and go straight in. If you're having to manipulate it and like jostle it, something is wrong, stop, check the pins, and make sure your connections are okay. Okay. From here, you should automatically have an image. It's going to autofocus, auto whiteout, and auto white balance. You don't have to do any pre-testing. The scope is ready to go and be used. Okay. As they're going through the patient, you're going to notice it's going to focus itself through, and they're going to have. You're going to see vocal cords through the sky. And as they go through, they'll be able to navigate the airway. Okay, there is nothing that you have to teach the physician on what to do. They will know what to do, okay? We're not changing how they do their procedure. We're just giving them a different piece of equipment to do it, okay? From here, if I had turned on the monitor on the way to the room, this is the view that I get. So it's prompting me to line up my arrows and go straight in. The green one is actually a double lumen tube and a single lumen ET tube with a camera on the end. And your OR actually has the single lumen ET tubes with the camera. And I'll show you that one too so you can see what that looks like, okay? So from here, I've got my battery life. I've got 3.5 hours. When fully charged, you have a 3-hour working battery, okay? If you can't turn it on, most likely your battery was dead. Plug it in during your procedure, it'll charge and you can still use it, okay? On the bottom, I've got a date and time for your timeout. Now with this scope, any pictures that I take or any videos that I do, and I can do a video and I can do a recording, a snapshot, they're populating on the side, okay? If I don't need that side to view, I can do a double tap and that'll give me a bit of a zoomed in view. Let me pull back so you can see a little better. So you see the difference from there to there, okay? And it's gonna continue to record until I tell it to stop. So I can tell this guy to stop recording. From here, any pictures that I take, I can hit the file folders. And every time you connect a piece of equipment to this monitor, it's going to create a file folder specific to that piece of equipment. So the top folder is going to be the last images that were taken. I can open with the eyeballs. Everything is going to be date and time stamped, but there is no patient identifier. Okay, so we actually recommend as you open the file folder, click on the pencil, and give it a patient identifier that's going to be HIPAA compliant. Whether it's your MRN, a date of birth, a physician name, you already have a date and time, you can always go back and say, okay, we did a bronch in unit 3 at this time, what was that patient's name? And most of your units keep a log file anyway. You're not going to be doing very much picture recording, just know that that capability is there for you, okay? The pie chart at the top is your memory. You've got 8 gigs of memory, which is like 1,000 hours of recording and 2,000 pictures. So that does fill up, and if at any point it's completely full, you can't do any recording on the main screen, but you can still do your procedures. You can always go back and erase it. Now there is a connectivity issue on the side. We can do a USB connection to take any images off. So if I connect my USB and I want to send the whole file, I can click the USB and it'll send it over. If I want to send specific pictures, I can put a halo around them and then send it over to my USB. I'm going to get a green check mark when it's done. I'd get a red X if it wasn't connecting appropriately. And then you should see the files starting to move over. So each piece of equipment gets its own file folder. Okay? What's nice is when you're done, you're just going to unplug the scope and all of this goes in the garbage. Okay? Single patient, single time use. Whether you do biohazard or straight trash is going to be up to you guys, but you tend to put bloody gloves in the garbage anyway. Just, you know, do what's appropriate. If it's a really infectious patient, you don't know what it is, I'd probably do biohazard. Then just turn off your monitor. Make sure it stays charging when you're not using it. It really likes to be charged. Any questions? It's relatively easy, I promise.
That's pretty simple.
Yeah, I mean, the biggest thing you're going to need is your specimen cup. You'll have your suction, your canisters on your wall. You'll need a bronch adapter, maybe an oral airway, some slip tip syringes if you have Luer locks. Remember, you have a connector on there, and maybe a bottle of saline, or even your sterile saline syringes, and that's it. So it's very small, very minimal space in the room. I think, did we get a red X? We might have gotten a red X. Might have not worked. Let me show you what a red X would look like. The other thing I was going to show you is this blue arrow at the top. That will take me back to the home screen. See, red X, nothing's connected. The blue arrow takes you back to the home screen, and then it's just prompting me to plug my scope back in. Do you guys have any questions? You're welcome to practice putting it in, holding it. You're going to notice it's very light. It's very easy to handle. I know you want to. Yes, you do. Yes, you do. Try and plug it in. That's going to be the number way you're going to break your monitor, is not plugging it in correctly. So make sure you just line up the arrows, plug it in, do a double tap on that screen. Remember, that'll give you that zoom.
Yeah, you say there's a green line, or you blew
a gray.
Gray line. Okay, just right there. Okay.
Yep, gray line up. And for the most part, you'll just leave everything in the packet, just kind of fish the cable out, plug it in, and that way your physician comes in, all you have to do is hand them the scope, hold out your lube, they'll lubricate it, and then go from there. Now you can connect it while it's still in there. And then double tap on the screen. You won't hurt it in any way if you practice on it, and that's your zoom.
I love that Hot Topic man over here has a really cool Corona and everything. You see that?
He's anatomically correct.
Oh, I mean, I was like, hey.
Yeah, he is.
Where'd that adapter go?
Oh, the slip tip?
There it is.
On the other syringe. Oh, yeah. Oh, there's the packet. Good eye. I thought I lost it.
Oh, I see.
There we go. So you see the little circular tab on here?
You'll have to use the adapter.
Is that what's usually attached to?
Yes. So it comes just like this. It's a little slip tip adapter. Now the other thing I'm going to put on your monitor is going to be a sizing guide. So just in case for some random reason you get into the room and you see a gray scope, that's the smallest scope there is. That will not work for you, okay? If you're doing washes and BALs and thick secretions, you always want to make sure you have that orange scope, okay? The smallest one is going to be more for just double lumens and OR stuff. So I'm going to attach a sizing guide to your monitor. It's going to tell you the ET tube sizes on there. If they want to use any of those endoscopy tools, that's going to be towards the bottom for the sizing of those. On the back, it's going to remind you about the slip tip adapter and all of those suction connections. Okay, so there is a sizing guide in case you forget 7-0 for that one. And really it goes 7, 6, and 5. So the next size down is a green scope. They haven't ordered it, but that's a regular bronchoscope. This is always going to be your better suction source. The bigger you go, the better your suction source is going to be.
The whole time I've been here, I might have saw one patient that had a smaller than 7 tube in them.
Yeah. Make sure you line them up. Yep.
And you did say that this adapter has to be attached if they're going to do any kind of biopsy or anything like that?
Yes. So you would actually put this into the working channel first, and then push your tools through. Okay. Because it's a plastic valve there. Yes. And if you try to push a biopsy brush through, and as you come back, you're going to squeegee your sample off. So this has to open up your port. Now, if there's anything in here and you go to suction, you're losing your suction source. If I have a syringe full of saline and you apply suction, it's going to suck your saline through. So nothing can be in that channel if they're wanting to suction. So it closes off that channel. Yeah. And the same thing goes if they haven't pushed that syringe all the way in and they're trying to push through, they're going to get splashed and overflow. So make sure they just seed that syringe all the way in. And it's really light, you know, and I can tie that in a knot, the patient can bite it. You're still going to have a view through there. It's pretty durable. It's a thin little optic wire that runs through it. So it's not like your reusables that are fiber optic glass. So if they get squeezed too tight, they break. And then to turn off,
I had to.
I know you did.
to turn off, you can just actually hold down or do 2 clicks, and then it'll turn itself off.
You said 45 seconds for it to come up.
Yeah, just, you know, turn it on as soon as you know that you're going to be using it. And then plug it in. That way it warms up the light a little bit too.
And full battery gets like 4 hours?
3 hours. It'll say 3.5 on there, but that's just a monitor battery.
Mm-hmm.
For usage, you have a 3-hour battery life.
Okay.
Which should be more than enough to go room to room a few times and then plug it back in. You're done for the day. Yeah, I promise it's relatively easy.
I imagine we're not going to go bronch crazy, but do one, plug it in.
Yeah.
Next day, I might have another one.
Yep. But at least you know you don't have to go reprocess this. I mean, it's
I think I know what I want for
100
Christmas.
steps process. Oh, you want a bob? You want a bob?
This looks really simple.
I mean, does it bring back memories for you of how you used to do it? Yeah. Yeah. Remember, the docs already know how to bronch. You're not teaching them to bronch. Just say, here's your new scope.
So we just set stuff up and stay.
Yeah, and hand them a saline if they need you to refill their saline syringe. Make sure your vent's on 100% and quiet. And then let them know if their patient's decompensating too much and they need to stop and give them a break. That's really it.